Hello everyone, welcome to this pediatric recall based session for FMGE January 2024 paper. The exam is already done and this paper, it was a mixed bag. It was definitely not on the easier side, but at the same time, it was not totally unsolvable. It was a complete mix. So here we are going to discuss some relevant questions here. Before I start, I want to emphasize that this entire session is based upon the recall by the students. So if options change or statement stem change, the answer is also liable to change. And many questions are integrated and they can be considered in multiple subjects. And understanding the way questions are framed is important for the future exams, and any resemblance to actual question is purely coincidental. And one more thing I want to add here is that in this recall session particularly, what we have done is we have taken a relatively large sample size of recall by the students, and many times what has happened is the same question has been recalled differently by different students. So in many places I have given different versions of the questions. So you are the best judge. All those who have given the exam, you would be able to see if this was particularly asked, this would have been the likely answer. And because there have been some controversies in the integrated areas, so to solve controversies, don't go by what I'm saying or don't go by what anyone else is saying. I have given you references, authentic references from standard textbooks also in most places, right? So I hope this recall is going to benefit you if you have given the exam, and all those who are going to appear in the next session of the exam of FMG, you are also going to benefit from it. So have a look at how questions are being framed and let us try to understand the pediatric questions here. So analysis, first of all, before we start with the recall, this time the pediatrics part was tougher compared to the previous exam. There are 3 to 4 repeats. These are mostly direct repeats which have been asked in the previous years. Tough conceptual questions were asked in neonatology, and there were 2 milestone questions. Some people said 3 questions were there, but again, it depends upon how you have recalled. And integrated questions were there both in paper A and paper B. So there were 2 questions of pediatrics which were there in paper A also. And one-liners are decreasing. As we have said before, I keep saying exams are becoming more and more clinical. So yes, one-liner will be there, but it will also be a part of a concept. So it is now time for you to make that transition for conceptual discussion. And pediatrics continues to be a scoring subject. And I would show you the snapshots. Direct lines from textbook of Nelson have been asked in the paper. That doesn't mean that you start reading Nelson. Nelson is a huge textbook, but relevant sections of that I always discuss in my classes, in my DocTutorials video lectures, in my offline classes. And it is important, it is imperative that you add and understand that why a particular concept is important, because derivatives of that are being asked in the exam. So let us start with question number 1. So question number 1 was something like this. A child presented to the OPD with gum bleeds. So the key word here is gum bleeds. There were multiple tender or painful costochondral enlargement of the ribs. There were bone pains, bowing of the legs, and pencil thin cortex of long bones on radiology. Which of the following will be useful to treat in this child? Now you need to understand that bowing of legs as well as costochondral enlargement, also called as rosary, beading of the ribs, can occur in both rickets and scurvy. That is, it can occur in both vitamin D deficiency and vitamin C deficiency. But what is the clinching point? Vitamin D deficiency will never have gum bleeds. So the first clinical point here is gum bleeds in the patient, right? So bleeding manifestations are a feature of scurvy. Second feature, which is a clue here, is pencil thin cortex of the long bones. There is diffuse osteopenia. There are metaphyseal changes in rickets, but pencil thin cortex is not described. Pencil thin cortex and Wimberger signs are signs suggestive of scurvy in the patient. So pencil thin cortex is another clue. So you have gum bleeds, pencil thin cortex, along with the other things. Third thing which you need to remember is that although bleeding of ribs can occur in both rickets and scurvy, it is always a painful bleeding of ribs. So painful rosary. If all the 3 you combine together, the likely diagnosis is scurvy, and scurvy occurs due to vitamin C deficiency. So which vitamin deficiency you are suspecting here? You are suspecting vitamin C deficiency, and that is your answer. So remember, if you get what for future exams, what are the clues you will look out for? If the MCQ examiner says that there is a patient having bowing of legs. If the question examiner is saying there is non-tender rachitic rosary, non-tender means not painful, no bleeding manifestations, no bleeds, and the question is saying patient is having cupping, fraying or splaying of metaphysis on X-ray, what will you likely think of? You will think of rickets as the likely diagnosis. On the other hand, if the MCQ says bowing of legs, tender rosary, it is also called as scorbutic rosary. Bleeding manifestations are present. Bleeds can be present from the gums, they can be present in the perifollicular hemorrhages, and painful bones will be there. Why painful bones will occur? Painful bones will occur because of subperiosteal hemorrhages. It is also a part of the bleeding manifestation happening in the patient. So subperiosteal hemorrhages, and the question is saying radiological signs like Wimberger sign. Question is saying pencil thin cortex. The likely diagnosis in the patient is going to be scurvy. So these are the keywords that you need to watch out for, and you need to have that precision in the exam. I keep saying in clinical question, if you know the keyword, you always reach the correct answer. Rickets is due to defective mineralization of the long bones. So mineralization will exclusively affect the bones. It will not have any bleeding manifestation. On the other hand, scurvy occurs because of vitamin C deficiency. There is defective collagen formation. Because of that, not only bony changes will happen, but risk of capillary bleeds will also be increased. So bleeding manifestation will be the very important clue that patient is likely suffering from scurvy. So bleeding gums, bleeding manifestation, painful bones, painful rosary because of subperiosteal hemorrhage, vitamin C deficiency should be suspected. What are the additional things you would remember in this such a question? Radiological signs in scurvy. So this is something you have read in radiology also. So radiological signs suggestive of scurvy include subperiosteal hemorrhages, pencil thin cortex, Trummer-Feld zone which is present just below the metaphysis, white line of Frankel present at the metaphysis. There is a Wimberger ring sign. It is also called as a ringed epiphysis. So the epiphysis becomes like a ring. So ringed epiphysis or Wimberger sign, and spurs at the metaphyseal end called as Pelton spurs. These are the clues that it is a scurvy patient that is being talked about radiologically. Look at question number 2. A child presented with malnutrition, cirrhosis and follicular hyperkeratosis. Which of the following should be administered to this child? So malnutrition child is there, so there will be deficiency of some micronutrient. What is the meaning of cirrhosis? Cirrhosis literally means dryness in the patient. So the literal meaning of cirrhosis is dryness. Dryness predominantly occurs in two parts. In patients of vitamin A deficiency, dryness involves the skin and dryness involves the eyes. In the eyes, it is the conjunctiva which shows conjunctival cirrhosis followed by corneal cirrhosis. And if you remember the WHO classification, conjunctival cirrhosis and corneal cirrhosis are primary signs of vitamin A deficiency or xerophthalmia. What is follicular hyperkeratosis? The skin, the follicles become unduly prominent. It produces a so-called goose flesh or a toad skin appearance. All of this is happening because of vitamin A deficiency. Vitamin A is responsible for mucus production and goblet cell function. And if vitamin A goes, among other things, these mucus production, goblet cell production will also be affected, and so you will have dryness. And this dryness is the hallmark of the patient. So which of the following should be administered to this child? Vitamin A should be administered to this child. Have a look here. This is something I have already discussed in my video lecture, that vitamin A deficiency, the earliest feature is defective dark adaptation, which progresses to night blindness. Many times you write it like this, that there is an old question also, I always tell in my class, that the earliest symptom of vitamin A deficiency is night blindness. Yes, correct. But when the question was asked in the exam, they did not mention the word night blindness. They mentioned delayed dark adaptation, which was the better answer. And whenever there is mild vitamin A deficiency, skin manifestations sometimes can precede the eye manifestation also. Can, not always, but can. And follicular hyperkeratosis is the typical skin manifestation. There is rough skin, dry skin, along with raised hyperkeratotic patches, which are perifollicular. It gives a goosebumps appearance. You all know what goosebumps are, right? So have a OP Guide 10th edition also says, page 101, it says mild vitamin A deficiency manifests with follicular hyperkeratosis of the skin with raised hyperkeratotic patches resembling toad skin. अब इसके ऊपर भी MCQ आ सकता है, one liner in the future. Examiners sometimes repeat the question, sometimes they repeat the topic. So what I am doing in this recall is not only discussing the topics and the questions, I am also discussing what all potential things for future exams can be asked for you, right? So toad skin, which vitamin deficiency should be suspected? Vitamin A deficiency should be suspected. And this is how follicular hyperkeratosis will look like. Can you see this type of an appearance? This is called as the typical follicular hyperkeratosis. It is also sometimes mentioned as, if it occurs in adults, it is also known as keratosis pilaris. But the word keratosis pilaris is usually not used in the pediatric population. And for future exams, you must remember that if the question says, keyword kya hai yahan par? What are the keywords? Xerosis, yani ki dryness of skin, ya conjunctiva, ya cornea, along with follicular hyperkeratosis in the skin, along with plus minus night blindness or delayed dark adaptation or white hot spot. So what is the likely diagnosis? Vitamin A deficiency. So when you will do revision, if you can't remember the entire thing, remember this particular point. This is how I'm summarizing the key points here, right? So this is question number 2. The answer is vitamin A should be given to this child. Let us move to question number 3. You can see easily, every FMG exam, lot of questions are asked on micronutrients and vitamins. So question number 3, infant is breastfed, but his mother is vegan. Some of you said, ki sir, it was a slightly lengthier question, but exact thing could not be recalled, but this was the gist of the question. So infant is breastfed, mother is vegan. Vegan people never take any animal product, including milk and milk products. And because B12 is present in the animal products or milk and milk products, so they will always be B12 deficient. And when they will produce breast milk, this breast milk will also be B12 deficient. I always tell you in the class also that B12 is normally found in breast milk. But if the mother is strict vegan, she will not have any B12, and so the baby will also develop B12 deficiency, right? So which micronutrient supplementation will be needed in a breastfed child? It is vitamin B12 deficiency. Vegan is always a clue for underlying B12 deficiency. Remember this, right? So Nelson 21st edition also says, read this. The remaining points are also important. You know this already. I want to highlight here. Look at this line. Nelson says breastfeeding infants of B12 deficient mothers are also at risk for significant deficiency. If you see, this question has been picked up directly from this line. And so the answer to question number 3 is D. I keep saying that doesn't mean that you start reading standard books. What it means is you should read conceptually. Whatever we teach in the class, not just myself, but all the other teachers, all the eminent educators also, we try to tell you the best possible thing. So don't try to take shortcuts quite early in your preparation. When exam is just 1 month away, then all these revision programs are good enough. But if you have 5 months, 6 months, there is still time. Please read conceptually, read theoretically, and practice MCQs. That there is no way you will go wrong in the actual exam. So question number 3, answer is D. Moving to question number 4. A child is diagnosed with acute rheumatic fever. He also has migratory polyarthritis. So there is a rheumatic fever patient having migratory polyarthritis. Multiple joints are involved. Which among the following shall be the preferred drug in the therapy? Now, some students said, ki sir, child was not mentioned. Now, I hope you know already that rheumatic fever is produced by infection. The trigger factor is infection with group A beta hemolytic streptococcus. Rheumatic fever is common in children between 5 to 15 years, and rheumatic heart disease, which is a sequela of the rheumatic fever, that is common in adult, right? So rheumatic fever will always be more common in children. So whether they mention the word child or not, the answer will not change. Now, which among the following will be the preferred drug in the therapy? Now, there is no role of digoxin and no role of furosemide, because digoxin is a inotropic agent, furosemide is a diuretic. Both of them will be needed in symptomatic management of congestive cardiac failure. Is there any congestive cardiac failure mentioned in the question? No, the child only has polyarthritis. So C and D do not have a role. Benzathine penicillin G, remember, it is given only for prophylaxis. Prophylaxis, prevention, not for the treatment or management of the underlying condition. What do we give here? Aspirin is given. In fact, if you read textbooks and guidelines, they say aspirin has a dramatic effect on arthritis happening. You give start high dose aspirin and arthritis will disappear, dramatically respond, and the patient will become pain-free, inflammation-free. That will not mean rheumatic fever has gone away, but aspirin is the preferred agent here. So, as per IAP 2022 guidelines on acute rheumatic fever, if the patient with rheumatic fever is having arthritis only, as in this question, you will use aspirin in the patient. Aspirin will be given in high dose, 50 to 70 mg per kg per day for 3 to 5 days. Then it is given for 3 weeks and then further half the dose and given for another 4 to 6 weeks. Total 12 weeks of therapy with aspirin is given in these patients. Right? So before we go further, similar question can be asked in the exam. So let us summarize the management of acute rheumatic fever. If you get a similar question, what are the things you should know? Treatment of rheumatic fever will be bed rest. Why bed rest? Because many times asymptomatic carditis will be there. That will if the child is doing exertion or playing, that will trigger onset of CCF. So bed rest for at least 2 to 3 weeks should be given along with suppressive therapy. What are we suppressing here? We are suppressing inflammation in the patient. And suppressive therapy, how to remember in the exam? If the question says patient is having carditis, carditis means inflammation of the heart, along with congestive cardiac failure. So you will use steroids in the patient. Which steroid should be preferred? Oral prednisolone should be preferred. Dose they will not ask in the paper. If the question says, tomorrow they can make a case like this, where arthritis will not be there, carditis with CCF will be there. So wahan par one of the option will be prednisolone ya steroid, and that will be your answer, right? If the question says there is carditis without CCF, carditis without CCF. Carditis without CCF means there are no symptoms of congestive cardiac failure, but ECG findings are present. So in these patients, you can use either steroids or aspirin. Either of the two can be used. But which is preferred? Nelson very clearly says steroids are preferred. OP Ghai also says the same. Right? So heart involved hua hai, to steroid has to be given. And third thing is, if there is no carditis, but arthritis present, then in these patients, oral aspirin should be given. And what will be the duration of therapy? Whether you give steroid, whether you give aspirin, the duration of therapy will always be 12 weeks. You would be surprised to know this is also a one-liner question in a past Neet PG question. So it can be asked in your FMG exam also. And those of you who will be clearing the exam, many of you will be clearing the FMG exam, then you have to prepare for the Neet PG and I9CT. So there again, this will be important for you. So remember this, add it to your notes. And I hope many of you marked it correctly in the paper. And what about duration of prophylaxis? Prophylaxis mein use kya karte hain hum? We usually use, the drug of choice is injection of benzathine penicillin G. So we use benzathine penicillin G. What is the dose we use? 1.2 million units intramuscular injection every 3 weeks. So once every 3 weeks, you will be giving the injection. For how much duration you will use it, this is the table that you need to remember. I'm putting the exact table from the latest edition of Nelson because many of you are still reading the older guidelines. Older guideline mein duration was different. Since 2019, it has changed. So if there is rheumatic fever without carditis, penicillin ke injection kab tak denge? Either 5 years or till 21 years of age, whichever is longer. If there is rheumatic fever with carditis, but koi residual heart disease nahi bacha. Residual heart disease means no valvular involvement like stenosis, mitral stenosis, aortic stenosis, regurgitation that was there. So no valvular disease, so you will give for 10 years or till 21 years of age, whichever is longer. And if there is persistent valvular disease, carditis hua in fever and a residual heart disease, patient is left with a stenosis or regurgitation. अगर नहीं था तो लेस ड्यूरेशन देना था, but now you will give for at least 10 years or till 40 years of age. Sometimes lifelong prophylaxis may be needed in these patients. So this is the duration of prophylaxis. If the patient is penicillin allergic, you can go for erythromycin or sulfonamides, right? Let's move further. Question number 5. Now, jaundice due to biliary atresia is suspected when it persists beyond what time? See, Newborns, this is a question related to newborn jaundice. So it can be considered in pediatrics. It can also be considered in surgery. But you need to understand, surgeons will operate. It is me. Me means the pediatrician who will diagnose that patient is likely suffering from prolonged jaundice and it is likely to be biliary atresia. So when will you suspect biliary atresia? Normally, physiological jaundice will disappear by 2 weeks. If jaundice is persisting beyond 2 weeks, suspicion of cholestasis should be considered, and the most common cause of cholestasis is biliary atresia. So it is suspected when it persists beyond 2 weeks. Some people said कि sir option था 2 weeks to 2 months. So अगर 2 weeks to 2 month answer option था, तो that would also be the correct answer. If you have to choose one, so 2 weeks is the best answer if it persists beyond 2 weeks. For first 2 weeks में it is not considered if it is biliary atresia. Biliary atresia will not have any other distinguishing feature apart from some splenomegaly in the first 2 weeks. It should be suspected only when jaundice does not improve beyond 2 weeks, right? So what does Nelson say? Nelson says, read this. You can read the entire information given in Nelson. It also says that in addition, it is talking about biliary atresia here. Any infant with new onset or persistent jaundice beyond 2 weeks of life should be screened with the total and conjugated bilirubin level to detect cholestasis. Or agar cholestasis hoga, then you will do investigations for biliary atresia, right? Remember this key point. Also, I hope you remember that newborns ke andar biliary atresia is the most common cause of cholestatic jaundice in newborn. Right? There is another reference I have taken for those who were having doubts. Children with biliary atresia present with persistent jaundice, clay-colored stools and hepatomegaly, and any child with jaundice of over 14 days should no longer be considered as physiological jaundice and should undergo evaluation. Evaluation for what? They are talking about biliary atresia here, right? Let's move to question number 6. A neonate with erythematous papule with few yellow-white lesions appearing on trunk on day 2 of life and disappearing in 4 days. Baby is otherwise healthy and normal. Likely diagnosis. Some of you said कि sir, photo was given. Some of you said photo was not given. Whether photo is given or not, history is very characteristic. Newborn hai, first week of life, there is a rash coming. There is papule appearing on the trunk. Some of them are red, some of them are yellow-white. So, what is the likely diagnosis? The likely diagnosis in the patient is going to be erythema toxicum. Many of you were thinking कि sir yellow-white तो pustule भी हो सकते हैं. नहीं. Transient pustular melanosis will always have a typical history. There will be a hyperpigmented base in a localized area on which small pustules will be forming. And they will use the word pustules. They will use the word hyperpigmentation and it will be localized. It can occur on any part of the body and it will not have a characteristic distribution that rash appears in the first 48 to 72 hours and disappears within 1 week. This is the typical history of erythema toxicum and that is the answer here. If you are still not satisfied कि sir yellow white कहाँ होता है, नाम तो erythema है. Nelson says clearly that it is a benign, self-limited, evanescent. Evanescent means आता है चला जाता है. Evanescent means which goes away by itself. Erythema toxicum occurs in 50% of full-term infant. 50%. If there were 2 kids born in your family, maybe some relatives' kids, 1 out of them could have been having erythema toxicum. So common this is. Preterm infects are affected less commonly. Lesions are firm, yellow-white. 1 to 2 mm papule or pustule with a surrounding erythematous flare. Sometimes only splotchy erythema is the manifestation and lesions may be sparse or they may occur clustered. So this is the erythema toxicum, always improves by itself. Before I go further and go to the next question, it's a hot topic, can be repeated in the future. So if I am an examiner and I have to put a question on newborn skin manifestation, yes, derma also it comes, but eventually if a newborn has something, it will come to pediatrician. Only when I am unable to understand, I will refer to a dermatologist. And in private practice, unless I have no idea or my response to therapy is not coming, I will not refer, right? So being a pediatrician, you also have to read about the skin diseases in children. So if I am a FMGE examiner or a Neet PG examiner, there are 4 things on which commonly questions can be asked. So there are 4 transient neonatal skin lesions. Transient means they are benign, self-limited, do not cause any problem, but you need to identify. First phenomena kya hoga? Look at this phenomena. They can put this picture or they can say that there are multiple
yellow-white papules occurring on the face, particularly nose and cheek region, and they will disappear slowly in a few weeks. These are nothing but what is called as milia. Milia typically occurs because of sebaceous gland or sebaceous duct hyperplasia. So sebaceous gland से जो arise करें, yellow white dot dot discrete papules as you can see in the picture, that is milia. तो आपका diagnosis, what will be the diagnosis in the paper? It will be milia. Look at the second. This is what the question might have asked. They would say that a newborn is having yellow white with surrounding erythema. So yellow white lesions भी होंगे and red lesions भी होंगे. Papules. These papules will occur on the trunk and they will appear in the first week of life and disappear in less than 7 days. Within 1 week they will disappear. Then in these patients you will think of the likely diagnosis as erythema toxicum. This is what the question had also said. Erythema toxicum. Erythema toxicum, also remember that when you do, although biopsy and investigations should not be done, with clinical experience you can make the diagnosis, but if you do biopsy or if you do apply right stain to the lesions, you will find that it is composed of eosinophils. So a lot of eosinophils will be present in these lesions. So that will be another clue that is this erythema toxicum, right? Another clue hai, और इसके ऊपर question has been asked in some other entrance exam. Thirdly, if the examiner says that there are multiple hyperpigmented macule is something which is non-palpable. So if there are blue-black hyperpigmented macules occurring on the back, buttocks, and the thighs, the likely diagnosis is going to be Mongolian spots. And Mongolian spots will take about 1 year to disappear. Sometimes they can persist for 2 to 3 years also, right? It is also a self-limited phenomena. And fourthly, this is the one which was creating confusion. This is what you call as transient pustular melanosis. Sometimes the word transient is not mentioned. So they simply say pustular melanosis. Transient pustular melanosis में क्या होगा? There will be a hyperpigmented patch of skin with overlying multiple pustules. Despite being pustule, it has a good outcome, and with conservative therapy, wait and watch, within a few days to weeks, this will disappear. Although the pigmentation part can take a few more weeks to totally go away. Why do they happen? We do not know. There are theories for them, but you can read about the theories if you take up MD Pediatrics, otherwise, or you take up dermatology, otherwise you will not need these theories anymore. Now, why am I discussing all this? Many of you might be thinking, sir, recall session mein why are you discussing? Because recall session, you can always, this is going on YouTube, you can always move forward, increase the speed and see the answers whether you have got it or not. But you also need to know the why this is the answer and why this is not the answer. So this video is also going to be a revision tool for you. For those of you who will be appearing in the June-July exam and the December exam in 2024, this will be a revision video for you, past paper recall. At the same time, for those unfortunately who just missed the mark, at least it will tell you where did you go wrong and how you are supposed to remember and revise, right? At the same time, I do hope and I do pray that all of you who are listening and who have appeared in the exam come out with flying colors. That is what we all feel from our heart. So let us move further. Question number 7. Now this is a repeat question, absolute repeat question, right? Exact repeat hai. Teenager female comes to OPD with complaints of delayed puberty, short stature, widely spaced hypoplastic nipple. Some people said, sir, hypoplastic word nahi tha, so it doesn't matter, widely spaced nipples. What is the likely karyotype? So everything fitting into this girl. This is a patient, this is a girl with the typical features of Turner syndrome. And Turner syndrome has what genotype? It monosomy of chromosome, of one sex chromosome producing 45XO, that is monosomy, and that is the correct answer, right? Question number 7 is repeat. There was another question on Turner syndrome. Question number 8. You are evaluating a patient of Turner syndrome. Which among the following will be seen in the patient? Right? Normal height, that is not correct. What you see is short height, short stature is present. Normal karyotype, absolutely wrong. What you find is 45 exomonosomy. Webbed neck, present. Decreased carrying angle, it is wrong. What you find is increased carrying angle. What is that condition called as? That is called as cubitus valgus. The carrying angle in the patient is increased. Look at this photograph. This cubitus valgus is increased carrying angle at the elbow, more than 135 degrees. That is called as cubitus valgus. So what is correct? What will be seen in the patient? Webbed neck will be seen. Now regarding the option, some people said ki sir, there was some rare atypical heart disease also mentioned in the option. I don't know whether it was mentioned or not, but if they say Turner syndrome mein kya hamesha hoga, what will always be there in the Turner syndrome patient? Webbed neck will always be a identifying feature mentioned in the question, and that is your best answer. Question number 9. A patient with micronutrient deficiency presented with stomatitis. So this is the fourth question on micronutrient deficiency in the paper, right? So stomatitis. What is stomatitis? Oral ulcers, aphthous ulcer is called as stomatitis. Glossitis. Glossitis means inflammation of the tongue, red swollen tongue. Diarrhea and sunburned rash in a necklace pattern. Some people said, sir, photo diya tha. Some people said, photo nahi diya tha. If the photo would have been given, that would have been something like this, looking like a Casel's necklace. Agar aisa nahi bhi diya hai, still, what is the likely diagnosis in the paper? The likely diagnosis, in case there is diarrhea, dementia, dermatitis. Dementia not mentioned, but diarrhea is there, dermatitis is there, and it is occurring in a photosensitive, sunburned kind of pattern. The likely diagnosis in the patient is pellagra. So patient is suffering from pellagra, and pellagra occurs due to which vitamin deficiency? Likely deficient micronutrient is niacin deficiency. So the patient is suffering from niacin deficiency. Now some people got confused. They said, sir, some people said, sir, pyridoxine की जगह riboflavin था option में, और अगर stomatitis, glossitis there, can it occur in pellagra? Yes, it can occur in pellagra. See, Nelson 21st edition says, first of all, Nelson क्या कह रहा है? It says that the lesions, the rash, it appears as symmetric areas of erythema on exposed surfaces resembling sunburn. And later on, they can evolve into the so-called Casel necklace, right? It also says the cutaneous lesion, ये जो rash है, it is preceded by or accompanied by stomatitis, glossitis, vomiting and diarrhea. तो रैश के साथ में क्या आता है? स्टोमेटाइटिस, ग्लोसाइटिस, वॉमिटिंग एंड डायरिया. सो ऑल्दो जो 4 डीज आप पढ़ते हो पेलाग्रा में, यू नो द 4 डीज ना, डायरिया, डेमेंशिया, डर्मेटाइटिस, डेथ, दैट इज देयर, बट दैट इज द कैरेक्टरिस्टिक फीचर. अपार्ट फ्रॉम दैट क्या होता है? You have stomatitis, you have glossitis, and you have vomiting in the patient, right? And if you see the way it has been mentioned in Nelson, somebody who was making this question had recently read Nelson, and he also put these points in a thing which you have already read. So don't overthink in the exam. Whatever you have read and characteristic thing is mentioned, you will mark it safely. This is pellagra and niacin deficiency is there, so niacin supplementation will be needed. Moving further, question number 10, it's pediatrics and ENT overlap. ENT also, you have read about them, and pediatrics also I teach in my class. So a child with Laryngomalacia, some case was given. Some people said, sir, image of omega epiglottis was given. Some said, sir, it was not given. They only mentioned omega epiglottis. So what is true? So basically they are asking what is true regarding Laryngomalacia. Let us go option wise one by one. Laryngomalacia is a condition. It's a congenital anomaly in which the supraglottic part of larynx is unduly flexible. And whenever child lies down in supine position, or whenever child exerts or cries, there will be partial collapse of the supraglottic larynx. It produces stridor in the child. So what type of stridor is produced? It produces intermittent, episodic stridor. Stridor is not distress. Stridor literally refers to noisy breathing. Noisy breathing arising from the upper part. It is not the expiratory part, and dyspnea word is usually avoided in patients of Laryngomalacia. Some rare patient can have distress, but that is a mild distress. Usually we say that is stridor, but no features of increased work of breathing. And it is intermittent or episodic, inspiratory episodic stridor, which is inspiratory in nature. I hope you know the funda that supraglottic lesions always have a inspiratory, subglottic and glottic lesions can have biphasic stridor. So intermittent episodic stridor, so C cannot be the answer. C is a false statement. Surgical management needed in most patients is wrong. Wait and watch is needed. Reassurance is needed. Most patients will improve by 2 years of age. So only reassurance is needed, right? Option number B, the stridor improves with supine position. It is wrong. Stridor worsens when the patient is put in supine position. and improves when the patient is put in prone position, right? So B, what are we left with? A option. And this is a one-liner, old one-liner. Most common cause of congenital stridor or congenital cause of obstruction in the child producing stridor, it is Laryngomalacia, and that is the correct answer. So question number 10, the answer is A. Question number 11. Now this was a tricky question. There are two versions I got. Answer is same, right? Version 1, they said कि बच्चा नहीं था. Patient presented with GTCS, generalized tonic-clonic convulsion, lasting more than 45 minutes. What is the appropriate management? And version 2 said pediatric patient था, 8-year-old with GTCS convulsion lasting more than 45 minutes. What shall be the appropriate management in the patient? Seizure, any type of seizure, including GTCS, 45 minutes से ज़्यादा चल रहा है, right? So this is a patient who's having status epilepticus. In a patient of status epilepticus, the first thing, whether it is a child or it is an adult, the first agent to be considered in the patient is benzodiazepine. And if benzodiazepine do not work or they fail, then you go for anti-epileptic agents like IV phenytoin or valproate or levetiracetam. That is the funda to remember. Look at the options here. Option number A, carbamazepine is not used. It's not a first-line agent in GTCS or in status epilepticus. Option number B, valproate followed by lorazepam. That is again wrong. Valproate is generally used as a first-line drug in GTCS epilepsy, but not in a status epilepticus patient, right? Levetiracetam followed by valproate? No. Lorazepam followed by levetiracetam. What is lorazepam? It is a benzodiazepine. And benzodiazepine, if it fails, then we go for levetiracetam or valproate or phenytoin. That is the correct answer. And so option, whether it was version 1 or version 2, status epilepticus, lorazepam is always the initial drug of choice in the patient. And that is the option number D here. Still doubts? Some of you had doubts when I answered you on a personal basis. Ki sir, why not valproate, why not levetiracetam? Have a look at these two images. This is pediatric guidelines, IAP guideline है, और ये medicine guidelines है adult का Harrison में, right? Medicine, pediatric guideline क्या कहती हैं? What do they say? They say within first 0 to 5 minutes in a status epilepticus patient, ये status epilepticus का बात हो रहा है, lorazepam should be given initially as the drug of choice. You see, lorazepam दे सकते हैं, if not possible diazepam, if not possible midazolam. So benzodiazepines are the first line agent, right? Harrison क्या कह रहा है? Harrison भी ये कह रहा है, impending and early status epilepticus 5 to 30 minutes. Harrison कहता है कि पहले 5 minutes में आप you try to stabilize the patient, take do airway breathing circulation, try to give dextrose bolus. पहला ड्रग जो यूज करना है बेंजोडाइजेपिन करना है, एंड उसके बाद if it doesn't work, either phenytoin or valproate or levetiracetam. So lorazepam followed by levetiracetam is the correct answer here. I hope there should not be any doubt here, and I hope you will remember these two tables also. You add these two tables to your notes, right? YouTube पे इसको pause करो, write it down somewhere for those who are targeting the future exam, and even if you are targeting NEET PG also, this table, this slide is going to be useful for you. So answer to this question is lorazepam followed by levetiracetam. Moving to question number 12. Tough question. I keep saying every paper will have, every subject will have 1 or 2 questions which are unsolvable. This was not unsolvable truly, but it was of a NEET PG INI-CET level question, not the level you will expect in a FMG paper. FMG paper, they ask more easier questions, more conceptual questions rather than, you know, protocol based question. This was a protocol based question, more in the INI-CET domain, not even in NEET PG domain. So question 12 says newborn hai, undergoing resuscitation, PPV chest compression diya, when will you give epinephrine, right? And the answer comes directly from what is given in Nelson. Nelson कहता है that epinephrine should be administered when the heart rate is less than 60 beats per minute after 60 seconds of both ventilation and chest compression or during asystole. So which is the option here? Heart rate below 60 per minute with chest compression and PPV for 60 seconds, and that is your answer. दोनों कर दिया, 60 second हो गया है, heart rate is below 60, you will give IV epinephrine, and the dose of epinephrine will depend upon what route you are giving. Venous and osseous dose is different, endotracheal dose is different. I hope you remember the funda which I always tell in my class, that you always first start with the initial steps, then you start with the positive pressure ventilation, then you do MR SOPA, that is ventilation correction, ventilatory corrective steps, then you do intubation. When you intubate, you give PPV along with chest compression. And if that is not working, then only you go in for epinephrine. And if PPV plus chest compression more than 60 seconds, equal to more than 60 seconds have passed with heart rate less than 60, then you will give epinephrine. And ek bar denge, nahi, you can continue PPV and chest compression, but epinephrine can be given every 3 to 5 minutes. And you will keep doing positive pressure ventilation and chest compression in the meanwhile. This is the summary of the resuscitation guidelines that we discussed in the class. So it was a tough question. If you got it right, brilliant. If you got it wrong, it's okay. You can still make up in the other questions. So question number 13, transferring objects from one hand to another is acquired normally by what age? Some people said 7 months, in one or two recalls they have said 7 months also, but most of the students have said so 7 months was not an option, right? So transferring object from one hand to another depends upon which reference you are using. It is 6 to 7 months. Nelson says 7 months, OP Ghai says 6 months, and Illingworth also gives a range of 6 to 7 months. So transferring object one hand to another is a fine motor milestone. Child will be first holding the object like this, then moving it like this, then moving it like this. This is called as transferring object from one hand to another hand. That comes between the 6 to 7 months, and so 6 months is the best answer. And this is something I've already discussed in my video lectures also, that mouthing comes between 4 to 6 months. In fact, Ghai says, the new edition of Ghai says, mouthing comes at 6 months, right? But other books give a range of 4 to 6 months. Bidextrous reach comes at 4 months. Unidextrous as well as transferring objects hand to hand comes at 6 months. But Nelson gives a range of 6 to 7 months. 7 month nahi tha option mein, and so 6 months was the best answer. Question number 14. Really tricky, I would say. Just listen to what I am trying to say here. There are two versions. Version means some people said कि sir ये पूछा था, some people said कि sir नहीं ये पूछा था. So you have to decide कि क्या पूछा था. You have given the exam, and I will just put information in your domain and you see what did you mark. Version 1 कहता है कि a child is able to bring objects to mouth. This is nothing but mouthing of the object. Putting everything in his mouth is called as mouthing of the object, right? Laughing loudly, right? And becomes uncomfortable when familiar faces are not around. तो इसको कहते हैं stranger anxiety. तो अगर तीनों चीजें प्रेजेंट हैं तो व्हाट इज द एज ऑफ द चाइल्ड? दिस इज वन वर्जन. सेकंड वर्जन क्या है? तीनों चीजें थी, ऑब्जेक्ट टू माउथ, laughing loudly, uncomfortable when familiar faces are not around, but what is the earliest milestone age of attainment among these? तो इनमें से सबसे पहला कौन सा आता है? This is the second version, what many of you said. तो देखो, first we need to understand mouthing of objects according to many Western textbooks comes between 4 to 6 months. But according to Ghai, it comes around 6 months. Right? Second is laughing loudly. Laughing loudly or laughs loudly, that comes at always by 4 months. तो सबसे पहले क्या आ रहा है? Laughing loudly आ रहा है. Right? उसके few weeks later you have mouthing coming. And then we have stranger anxiety. Child is afraid of new faces. Recognizing strangers, not going in their arms. That is stranger anxiety, which comes between 6 to 7 months. Right? तो वर्जन 1 अगर है, वर्जन 1 है, तो आपका आंसर क्या होगा? 4 मंथ, 7 मंथ, 9 मंथ, 12 मंथ. तो वर्जन 1 में वो कह रहे हैं माउथिंग इज देयर, लाफिंग लाउडली इज देयर एंड स्ट्रेंजर एंजाइटी इज देयर. ऑल थ्री टुगेदर कब आएंगे? देखो, माउथिंग आ गया, इट विल गो अवे बाय 1 year ऑफ एज, राइट? सो 1 year तक वो रहेगा. लाफिंग लाउडली, you and me, we also laugh loudly sometimes, right? So laughing loudly will also persist. Stranger anxiety will come at 6 to 7 months, right? तो कौन सी एज है जिसपे तीनों होंगे? तो अगर वर्जन 1 है तो आपका आंसर विल बी बी, that is 7 months. So if this was the question, the answer is 7 month. And if question was version number 2, if the question was version number 2, वो पूछ रहा है कि सबसे अर्लीस्ट माइलस्टोन कौन सा आएगा? सबसे अर्लीस्ट आएगा लाफिंग लाउडली. और लाफिंग लाउडली कब आता है? इट कम्स एट 4 months, एंड सो योर आंसर बिकम्स ए, दैट इज 4 months. So you understand why recall sessions are so tricky? Because if there is a change in the language, the answer also changes in the question. And that is why whatever score, if you are calculating, if you're not calculating, great, right? But if you are calculating a score, always keep that error margin. If you are getting a good score, 170, 180 plus, job well done. But if you are on border or if you are just below border, you can get more score than what you are getting. You can get less score than what you have calculated. So it is not over till the exam results are out. And it also means that this was another tough question in the paper. So the newborn resuscitation question was tough. And this question number 14 is also very tough. One of my family friends and their son related to me, doing his psychiatry from Chandigarh, Neet PG, good rank. I asked this question to that guy and he also said, sir, I don't know. It's a very tough question. CT ka hai kya? This is what he said. I said, no, it's FMG question. So now you understand that tough questions are being asked. So read conceptually, that is all I can say. So question number 14, depending upon what the question was, I have given you in your domain, you decide what was the correct answer here. My thing is, purpose of this session is not to, tell you that this is right, this is wrong. I am trying to do multiple things, tell you what could have been asked, what has been asked, and how these things can be repeated in the future. You need to be prepared for those. Not only for FMG exams, but also for NEET PG and INACT. Question number 15. A child presented with diarrhea. He was eagerly drinking and skin pinching was going back slowly. So eagerly drinking, increased thirst, and skin pinch going back slowly is some dehydration. I hope you know that in a diarrhea child, there are 3 categories of dehydration according to WHO, IMCI and IMNCI. You have, if the child is not thirsty, skin pinch is normal, and the child has a normal active state, we say no dehydration. If repeatedly asking for water, thirsty child, eagerly drinking, and skin pinch is delayed, some dehydration. And in these are the patients who will require ORS. And in case there is unable to drink child, stuporous or lethargic or comatose child, in such a child, it will be severe dehydration. And some dehydration, we give ORS. These are the patients who are categorized as yellow according to the IMNCI classification, right? So look at this chart. So this is the color coding which is done. So in case there is no dehydration, that is green, these children can be managed with home-based fluids like ORT, home-based fluids can be given. In patients who are having some dehydration, they will be labeled as yellow. So restless, irritable child, sunken eyes, drinking eagerly and thirsty, skin pinch going back slowly, some dehydration, they will require ORS. And pink child will be severe dehydration. Very early, in some of the other countries, they use red color, but in India, we use IMNCI, we use pink. So pink will be severe dehydration. They will require IV fluids. These are the patients who will require IV ringer lactate, and if you are sitting in a PHC, you will refer to higher center. If you are in a higher center, you will admit the child. If 2 of the following signs are present, lethargic or unconscious, sunken eyes, not able to drink or drinking poorly, skin pinch going back very slowly, that will be severe dehydration. So because this child is having some dehydration, so what category? Yellow category will be considered here. Question number 16. Term neonate with respiratory distress, cyanosis, increased work of breathing. On auscultation, breath sounds on the left hemithorax, chest x-ray showing multiple air bubbles in the left thorax. So thorax may, if there are air bubbles and bowel sounds are heard, something herniating on the left side. So it is nothing but congenital diaphragmatic hernia. Some people said image was given, some said image was not given. Majority said image was not given. But image, if you have to see, can you see here that on the left side, there are air bubbles, multiple air bubbles present, and there is a mediastinal shift which is happening towards the right side. So when you do auscultation, you will find that the bowel sounds will be heard in this area. This is what you call as congenital diaphragmatic hernia. So remember the funda that whenever there is a newborn or an infant having a scaphoid abdomen, or there is a patient who's having a mediastinal shift, newborn having a mediastinal shift along with bowel sounds heard in the thorax, get an chest x-ray and rule out congenital diaphragmatic hernia. Chest x-ray will show what? Multiple air bubbles in the left hemithorax. And in these patients, I hope you know that bag and mask ventilation will be contraindicated, which is a separate MCQ asked in the previous FMG exam last year. It had been asked, right? So congenital diaphragmatic hernia is the answer. Question number 17. There was one question on neonate who was having less surfactant or less lecithin and collapsed alveoli. This was asked in paper A, as I have been told. So it could have been a physiology question, but physio-pediatric overlap, I would say. And collapsed alveoli. So what is the likely diagnosis? Respiratory distress syndrome, also called as hyaline membrane disease. The options could not be recalled, but there was a question similar to this. So this was an easy one, and I hope most of you would have got it right. So RDS was the answer. And question number 18. Failure of closure of anterior neuropore at what time is responsible for producing the congenital defect as shown? Look at this defect. What is this child having? This child is having the condition known as anencephaly. Absence of forebrain formation. Overlying scalp here, they are also absent. Anencephaly usually occurs because of problems in the closure of anterior neuropore. So basically they are asking is at what time, if anterior neuropore does not close, it will cause anencephaly. The answer is not 3 weeks. Many of you marked it as 3 weeks. The answer is actually 4 weeks. 4 weeks is the answer. Why? Have a look here. All the review articles, textbooks, they clearly say closure of anterior neuropore kab hota hai? It occurs on day 25, that is 4th week. Dekho, 0 to 7 days is the first week. 7 to 14 days is the second week. 14 to 21 days is the third week. Right? So 4th week mein, if the anterior neuropore does not close, then it causes anencephaly. So the answer here is 4 weeks. Failure of this process. So firstly, on day 25th or 4th week, closure of anterior neuropore occurs, developing into the lamina terminalis. Failure of this process leads to neural tube defect at the cranial end, for example, anencephaly. So this is a question which is, again, pediatric and anatomy, embryology part overlap. So answer is 4 weeks, right? Question number 19. There was a question, options could not be recalled properly. A question on a patient with hemolysis. Some people said, sir, hemolysis ke saath mein they are also mentioned a raised unconjugated bilirubin, which will again be suggestive of hemolysis, right? Finger pain, swollen fingers which are inflamed, dactylitis, avascular necrosis was mentioned, and chest pain was also mentioned. What is the likely diagnosis? Hemolytic anemia, where chest pain, microvascular occlusion, and finger swelling occurs. It is a crisis occurring in sickle cell anemia. And so the likely diagnosis, one of the option was related to this. So sickle cell crisis or sickling crisis was one of the option, and that was the correct answer. Sickle cell anemia is something which is again pathology, medicine, pediatric overlap. If you remember, close to the exam, I had told you sickle cell anemia. In my classes, I've said sickle cell anemia is a trending topic. Nipah virus is a trending topic, and there were questions asked on these. So whatever is trending, whatever is important, whatever diseases are there in the news, you are supposed to read them close to the exam if they are important. And have a look here, like in my lectures also, I have discussed that in sickle cell anemia patient, there is a vaso-occlusive crisis. Usme kya hota hai? Sickle-shaped RBCs, they cause occlusion of small vessels producing ischemia. Hallmark is pain. What is the first sign which appears in infancy? So actually it is a pediatric presentation, can occur in adults also. So bachchon mein zyada common nahi hai. So that is why I have included in pediatrics part, right? Kyunki we see it actually more than the medicine people. So it will be mostly seen in infancy, where there will be dactylitis or hand-foot syndrome, painful swelling of fingers and toes, bone pains will occur. Sometimes it can cause avascular necrosis of femur. There can be renal papillary necrosis causing isosthenuria, stroke in age less than 18 years. Which hemolytic cause will you suspect? One important cause is sickle cell anemia, and crisis will be the reason. And corpora cavernosa in males, including children, can cause painful priapism. If it is more than 4 hours, you need to hospitalize. If the similar ischemia occurs in chest, that is called as acute chest crisis. And acute chest crisis is also a variant. And if you see hemolysis, finger pain, dactylitis, avascular necrosis, chest pain, everything pointing to a crisis happening in sickle cell anemia. Sickle-shaped RBCs stick to each other and block the small vessel, producing ischemia. That is what is happening here, right? So answer is sickle cell crisis, sickling crisis. You can solve this question only when you have read conceptually about sickle cell anemia. And lastly, questions which were probably asked, there was no recall there, so I will not frame the question myself. Some people said Down syndrome pe tha, some said nahi tha, so I don't know what it was. If you find it, you are most welcome to share it, and I will try to answer. Some people said CSF findings in meningitis pe bhi tha. Many said ki sir nahi tha, so again I have not put them as recall. So if you see paper, there were tough questions, there were integrated questions. Some were purely pediatric, of course. All the questions I discussed, majority of them are purely pediatrics. Some of them are overlapping with other subjects, but if you have read conceptually, at least 90-95% of them can be solved easily, and some of you have solved them, as I have got the messages also. But end of the day,
Don't lose hope till the exam is done, and in case something goes wrong, learn from the mistakes. But I do hope and I do wish all of you come out with flying colors as soon as the results come. May God bless everyone and may everyone pass. Thank you so much.